thanks everyone for attending for another applied analytics seminar. We've got Archie Campbell this time to talk about the pros and cons of a record linkage, I believe, Archie. And the usual drill. We'll run through for 40-50 minutes, and then I'll compare the questions at the end. So if you would, Archie, take it away.
Okay. Yep. So thanks, Dave. Sorry about having to reschedule this a couple of weeks ago due to ill health at the time. So yeah. So now my name's Archie Campbell, and I'm the Chief Technical Officer at Generation Scotland. I've been working for Generation Scotland in various capacities for 15 years now. And okay, just panicked for a minute. It looked like my PowerPoint wasn't moving, but it did eventually. So today I'm going to tell you a bit about Generation Scotland and the data sets we have, and then how we've linked them to medical records, and then talk about some of the pros and cons of what we can do with those medical records. And I'll probably take about 45 minutes at the most, try and leave a fair bit of time for questions at the end. So Generation Scotland is basically set up as a genetic study, though we're interested in all aspects of disease. And in our initial recruitment stage, in our main study, we recruited 24,000 people within Scotland from families, from about 7,000 families altogether. And this recruitment took place during 2006 to 2011. And we got most of our people to attend the clinic, and we measured the sort of things you can measure in the clinic, heart rate, blood pressure. We did an ECG on them. We did spirometry, lung tests, lung function testing. We got them to fill in questionnaires. We did cognitive testing. We did some testing, some questionnaires about mental health as well. And we took blood samples and urine samples, and from the blood we've extracted the DNA in order to do the genetics. And this is our sort of baseline data set. We collected all this data from our volunteers. And as part of the consent, we asked them for consent to link to their medical records. It was optional whether they would consent, but over 95% of them did. We also asked for consent to be able to recontact them for further studies in the future. And again, most of them consented to do this. So just a word about where we recruited people from. Now in Scotland, there are 14 area health boards on the map here. And our recruitment was basically in Tayside, that's this bit here, mostly in Dundee, and in Glasgow, down here. And later on in the recruitment phase, we also recruited some people in Grampian, Aberdeen, around here. We do have some participants from other parts of Scotland, but that's mostly because there were family members who then travelled into a centre to take part, or else about 10% of the people only took part by post. We got a saliva sample from them to get the DNA, and they just did the questionnaires and not the clinical tests. So in order to do linkage to medical records, within Scotland, we had this thing called the CHI number, stands for Community Health Index. Everyone registered with a GP in Scotland gets a CHI number. And the way a CHI number works is it encodes the person's date of birth in day, month, year order, which is the wrong order from my IT point of view. It'd be much better to be the other way around. But it's day, month, year, then a 3-digit number, which is unique to this person. And then the last digit is either odd or even according to whether they're male or female. And this CHI number belongs to the NHS, and they guard it very jealously. And we're not really allowed to know what the CHI number for these people are, but we can get the NHS to find the CHI numbers for them. And to this, we can then link to the medical records. And everything that the NHS in Scotland does is linked to a CHI number in some way. And the other data sets that we can get hold of, to start with, there's a lot of abbreviations coming up here, I should warn you. So the main one is the SMR tables, the Scottish Morbidity Register. And in that we get the outpatient attendance and inpatient in hospitals. There's the maternity database, as mental health database for people who are actually inpatients in a mental health facility. The cancer registry has all details about people's treatment for cancers of immunotherapy, chemotherapy, etc. And then there's the sort of partner to the maternity database, which is about the mothers. There's database, the data about the babies, originally in one table until 2002. Then they changed the format into a separate table. But all of our participants, because they had to be over 18 at the time of recruitment, are actually all born before 2002, so they all come into one table. And we can get the prescription data from the prescription information system, the PIS. And these are prescriptions actually dispensed by the chemist, because this table is taken from the data used by the NHS to pay the chemists for dispensing the prescriptions, which are free in Scotland. And not finally, but next, we have the General Register Office of Scotland, which gives the information on mortality from the death certificates. We can also get other data. We get data from the NHS dentists. I can't remember what MIDA stands for, something to do with dental systems. And again, this is the data. This is the database from the forms which are used to pay the dentists. So it doesn't give us particular information about what the dentist did, but it gives us information about how much they were paid to do it. So we can tell if it's a filling or an extraction, etc. But it's not a huge amount of information about the dental health of the people. We can get information from the Sky Store, the Scottish Care Information Store, which gives us lab results. And these are results for routine lab tests ordered generally by a GP. You go to your GP and your GP says, oh, we'll take some blood and run some tests just to see if we can figure out what's wrong with you. We can get all these results back. The difficulty with the Sky Store lab results is that there's no national database for this. The others are national databases, but Sky Store, we have to go to each individual area and get a download from each area Sky Store. We can get GP records. I'll come back to the GP records in a bit more detail later. There's a lot to say about those. We can get admissions to accident and emergency. We can get data from the NHS 24 online system and phone system. Information about GP out of hours attendance. More recently, we've had a great interest in getting information on virus tests for coronavirus testing. So you've got tested positive and negative, and also information about who's been vaccinated and when. And finally, we're about to get access, we hope, to a new national database, which will give access to all the scanned images from all kinds of different scans done in hospitals throughout Scotland. We haven't actually got this yet. We're still waiting to get the final permissions for it, but we were assured the data is there, and that once we've got the permissions, we'll actually be able to get access to these images, not just the images, but also the text reports that go along with these scans. So just to give you an idea of the timescale we have for these, most of these databases will go back 20, 25 years at least. Some of them have been collected for something getting on for 40 years. So there's a lot of information to be had over the many years. And also there's Guthrie card data has been collected since 1965. I'll talk a little bit about Guthrie cards at the end if I've got time, but it's not really part of this talk. It's worthy of a whole talk on its own. So to give you an idea of how much data we have from each of these tables, right over on the left here, we've got all the people that we have chi linkage for. And the different colors, the blue ones are the people that we've got genotype data for. We've got GWAS, I'll come back to GWAS in a bit. And for most of them, we also have DNA methylation data now as well. So we've got genotype data on about 20,000 people with chi. One of the main things we can get information is the SMR0 outpatients data. The top of that is that all it tells us is that somebody attended an outpatients department, which department it was and when they did it. It gives us no information at all about why they were there, what happened to them when they were there, and what the result was. SMR1, hospital inpatients, on the other hand, that's got loads of data in it. We get up to 6 different condition codes when the person was admitted, when they were discharged. If they had an operation, then there's various operation codes. And it's all coded with ICD-10 coding. SMR2, this is the maternity data, and we've got maternity data on something like 3/4 of our female population in the cohort, up here in the maternity data somewhere. SMR6, the cancer registry, we've got about 4,000 people so far that have had cancer at some point. SMR4 is the mental health registry, and there's very few people in that because there's not that many people are actually mental health inpatients. Since recruitment, by now over 1,500 people in the study have died. We get information from the death certificates about cause of death and date of death. Prescribing data, nearly everybody's been prescribed something at some point, so there's loads and loads of data in there. Can be a bit difficult to interpret sometimes, particularly if you're interested in things like dosage, because dosage can be described in a multitude of different ways by GPs. And what the chemist does is they just write down on the dosage thing whatever it was that the GP wrote on the prescription. Dental data, again, most people in Scotland who go to dentists are registered with an NHS dentist, so we can get quite a lot of information about people attending dentists, but not a great deal of information about what actually happened to them while they were there. Lab tests, again, pretty much any time you go to the doctor with anything serious, they will probably run some blood tests on you. So there's lots of lab test data about people over the years. Again, GPs, most people are registered with a GP. The reason that we haven't got data on everybody is that we can't get data from all the GP practices yet. And I'll come back to that in a bit more detail later. Accident and emergency. It looks like nearly 3/4 of the people have been in accident and emergency at some point, which makes you think that they must be really accident prone. In fact, this is more because people being admitted to hospital, sorry, I've gone too far back. People being admitted to hospital often go to A&E first and are then triaged there before being admitted. So a lot of the people that are in here in the A&E list are actually being admitted into SMR1. We get more information in SMR1 about why they were actually admitted to the hospital. If they just had a plaster put on their broken leg and sent home again, we can find it in the A&E data here. GP out of hours, there's quite a lot of GP out of hours data to be had. Similarly, a lot of people use the NHS 24 system now. Most of the cohort at some point have got data on their COVID testing. And again, nearly all of them at some point have got COVID vaccinations. Probably the ones that haven't are the ones over here that have died beforehand. So lots of data there. Let's give you an idea of the sort of things that we get information on. This is quite an old slide about the top 30 conditions in the hospital admission data. And over here on the right, we've got an idea of the age profile of our cohort. They're about 60% female on the left-hand side, and they tend to cluster around late middle age from say 50 to 70 at recruitment. And they're all about 10 to about 15 years older now than they were when we recruited them. In fact, these are the current ages in 2016 rather than the original recruitment ages. So commonest things, this is also colored according to whether the condition was prevalent and occurring before recruitment to the study or instant after recruitment. So things that happen to people more in early life, like say appendicitis, tonsillitis, etc., they tend to have much more blue, and the things that happen to people later in life, like being diagnosed with cataracts, tend to be much more prevalent, instant rather than prevalent. So one of the things we can do with our cohort, because we're a genetics cohort, we've got the DNA, we can do GWAS, which stands for Genome-Wide Association Study, where we look at about 1 million variants across the genome, and test the association of the different variants with a particular trait. In this case, we're looking at the ALP level in the routine lab tests, alkaline phosphate, which is relevant for either liver or kidney disease. I can't remember which offhand. When you run the GWAS, we plot the results in this thing called a Manhattan plot, where it puts a spot in for the probability of the association with each of these million things. And the various chromosomes, the 23 chromosomes across the genome, are colored in different colors. And the height of the line on each variant gives you an idea of the significance of the probability. And there's a magic red line across here, which is the Bonferroni correction for multiple testing. If it's above the line, it's significant. If it's below the line, it's not. And what this showed us, why we did this, was to show us that by doing a GWAS on the routine lab tests, we can get much the same result as if we'd actually done all this testing on the result on the samples which we collected at baseline, or if we'd actually got people to come into a clinic and taken their blood, especially in order to measure ALP levels in their bloodstream. So what it shows is that just using the routine lab tests, and most routine lab tests come back normal. So we're getting a fairly sort of random selection of ALP across the population. But doing this, we can get exactly the same sort of results as if we did a dedicated study in ALP, and then comes up with the same associations that we would expect to find. And of course, doing a routine lab test is much cheaper than doing the assays yourself and collecting the data, the samples yourself in order to do it. So that was just a quick whiz around the sort of data sets that we have in the medical records. And now, going back to the title of the talk, I want to talk a bit about the pros and cons of using these medical records for various research purposes. One of the main pros is that relatively, it is pretty cheap to get the data this way. It costs us roughly around £25,000 to get the data release of all those data sets I was showing you earlier. We can get periodic refreshes. We generally get an annual refresh on most of the data sets we've got. We've not been able to get annual refreshes quite so often over the last couple of years for obvious reasons. But during the COVID pandemic, we've been able to get monthly data update on the things that are relevant for COVID research in order to help us take part in various consortia looking at COVID in detail. So the hospital inpatients, the mortality data, the GP out of hours, NHS 24, the ECOST and vaccination data, been able to get monthly updates on that. So be able to keep track on how our cohort have been doing across the last couple of years of the COVID pandemic. The data we get is population-wide. It's right across Scotland. If we've recruited people anywhere in Scotland, then we can probably get most of their NHS data from them, for them. And this gives us less selection bias than if we were, say, just collecting people that all suffered from, say, diabetes. The data is nicely coded. All the SMR data has ICD-10 codes, unless it's before 1997, in which case it's ICD-9 codes. And GP data has got read codes. And we can combine these with the phenotype algorithms that have been developed by Calibre, and now the HDR Gateway have taken over the phenotype library, and also Open Safely have got their own selection of phenotype algorithms that we can apply to this data. The data is all QC checked by the NHS IT department before they give it to us. They do a pretty good job on it generally. They also give us extensive documentation. They give us the metadata about it. They give us the data dictionaries, so we can interpret all the coding quite easily. And by knowing who has had diseases, and just as importantly, who hasn't had diseases, we're able to do some case control selection And if a researcher is actually looking for disease-free controls in order to do a study, we can look at people's records and see who, as far as we know, hasn't had the disease they're looking at, and give them control samples to use instead of just looking at cases. So those are some of the pros. Obviously, one of the main pros is that we could just do lots of different research. We can do all this GWAS and DNA methylation and all the rest of it on the 20,000 people that we have permission to do it for. So on the minus side, one of the main minuses, it takes a long time to actually get the permission. Once you got it in place, it's not too bad, but it can take a long time to get your permission, which comes from in Scotland, from the Public Benefit and Privacy Panel. Within the department in NHS Scotland, Public Health Scotland, that deal with this, there's a high turnover of the analysts that actually work on this stuff. We've been getting linked data for the past 7 years, and in that time we've had 6 different analysts working on our data. So they just get used to getting familiar with what Generation Scotland does, and then they get moved on to another job. So we have to start again with a new analyst. The data we're getting is collected for administrative purposes. It's not collected for research. As I said, with something like the prescribing data or the dental data, it's collected in order to pay the chemist, the dispenser, or to pay the dentist. It's not collected for us to be able to do research on it. So it doesn't necessarily give us all the information we'd like to have if it was being collected for research. But we just have to put up with these things. GP data. Although we have consent for the patient, from the patients to get their data, because GP practices are in fact independent businesses and consider themselves to be data controllers of the data they have for their people, we have to get their agreement in order to get the data extracted from each practice. There's about 1,000 GP practices in Scotland, and in order to get the data from them all, we actually have to get permission from each of those. We were in the process of applying to get all this GP practice consent in 2020 when we had to stop it all because of COVID. So far, we've got consent from about 40% of the practices, and we hope to get it back again. During the pandemic, the requirement to have practice consent was actually being waived, but it's only been waived for COVID-related research. So although we can get data from all the practices, or nearly all the practices now, we're not allowed to use it for any type of research other than COVID-related research, unless we have the practice consent as well. We're hoping that in about a year or so, we'll be able to get most of the GP practices to give us the consent in order to do this. There are also differences between some areas. I said in the lab test data, we get data from each area health board separately. Each area health board has its own local coding that they use to describe the codes. So in some of them, say a cholesterol test, maybe CHOL in one code and just CH in another. See, we have to compare, we have to find out what all the codings are and amalgamate them together in order to amalgamate the data for each particular test. Also format differences between different areas. Also, we discovered that in some areas, they do some tests that they don't do in other areas. It's just different area health boards have different policies as to which assays they're prepared to run in their labs, which assays they're able to run in their labs. They usually are all the same assay run in the same way in different labs, but we can't guarantee that in all cases. So sometimes there are some slight differences in the way they're doing particular assays. You have to watch out for that when you look at a particular battery of tests. Also, the data is incomplete in many ways. The trouble is we can sort of spot that it's incomplete, but we don't know exactly to what extent this is. I've mentioned the inconsistent formats before. This is particularly the case with the GP data. In Scotland, the GP practices use two different systems, Vision and EMIS, and they code all this stuff using read codes. Read codes are a very comprehensive coding system, but there's two versions of it currently in use, and one system uses 5-character read codes, and the other system uses 7-character read codes. So to combine them together, you have to watch out. Luckily, the two characters on the end are not particularly significant, so it doesn't make too much of a problem in most cases. So we're getting some background noise coming in. Anyway, so linkage issues. Once we actually started to do linkage, we discovered that the linkage wasn't quite as perfect as we thought it might be. Everyone in Scotland is supposed to have a unique Chi number, but some people have more than one Chi number. We discovered that in the generation of Scotland, we were able to tell that the most Chi numbers that anyone had got was 6. We're told that the record for having different Chi numbers is in fact 32, and that there's a whole department of the NHS IT department who look after the Chi register, who just spend all day trying to resolve the different multiple Chis that are generated by people. So usually if when people move from one practice to another, until they've got their records transferred from one system to the other system, they get a temporary Chi, and then they have to go back to their original Chi once the temporary Chi is no longer in use. Also, if you turn up at hospital unconscious after an accident or something, they have to give you a Chi number in order to book you into the system. So they will just give you a Chi number until they can find out who you are and what your proper Chi number is. So there can be multiple ones. When we first got our mortality data, we discovered that 4 people that we got data for their date of death and cause of death had in fact died before they'd attended the Generation Scotland clinic. So we thought, okay, this linkage must be wrong. We looked into it in some detail and find that probably the linkage between the General Register Office and the NHS was where the problem was. But because of that, because we didn't know exactly where the problem was, so the linkage of these 4 people have had to ignore. And this showed us that we'd had this, there were 4 people out of about 800 who had this problem where we could tell that in fact the Chi linkage was wrong. The thing is that the Chi linkage may be wrong in a few other cases, but unless we have that sort of alive or dead binary thing to test them on, it's quite hard for us to tell whether the linkage is in fact correct. Usually we can, but in not all cases. Luckily, because we're not actually basing anybody's treatment on knowing the right Chi, we're just using it largely for statistical purposes to do things like GWAS, where if you've got a few wrong cases or wrong controls, it doesn't really matter. They will disappear into the noise of the statistical probability. If we're basing actual people's treatment on the Chi linkage, then we'd be taking much more care about finding out that we had the right person in each case. And also we found that there are quite a lot of data entry issues, which I'll speak about in a bit more detail. So in the SMR1 data, there's a field where it gives us the date of birth, which is recorded in SMR1, and also the sex is recorded in there. And the data set I was doing this investigation on was up to about 30 years, 40 years, which is 2019, covered over 19,000 individuals and nearly 140,000 hospital admissions. 250,000 different condition codes to look at, most of them in ICD-10. Then I looked at to see if there's any inconsistencies between the date of birth. This is an example. There's 296, which is 1.5% of the ones that got some difference between the date of birth between one record and another. This particular example, we think the correct date of birth is these are in year and month format only. we think that November 1948 is in fact the correct date of birth, and that where it's been put in as 1948-01, that's probably just a typo, a 0 instead of a 1. And similarly, where it's been put as 1940, that's a typo of a 0 instead of an 8. Now, generally speaking, we don't actually care what the date of birth is exactly. We just want to know roughly how old they were when they got a particular thing happened to them. So if the month is a bit wrong, we don't really mind. But if the age is in fact 8 years out, then that can make a bit more difference to our analysis. In most cases, we can see that in fact it's probably correct, and we can probably tell what the correct one is. But also, we looked at any inconsistency between sex, and we don't think this is anything to do with any sex changes or trans people that are being in the cohort. I think these are just pure data entry errors, and there were 66, 0.3% of things had 2 different sex recorded against their data. And the ironic thing about this is all done using the Chi in the first place, and the Chi actually encodes the date of birth and the sex in it. So you'd think that there would be some way that they could do some sort of QC to check that in fact the Chi and the date of birth and the sex were correct. But it could be that the use of temporary Chis is making this very hard for them to do in some cases. So although we could see that there were inconsistencies in well over 1% of the data in something that we could actually spot, it could be that there are inconsistencies in up to 1% of these 250,000 condition codes. And some of these may actually be miscoded. Again, very hard for us to tell. Just on the question of ICD-10 codes as well, we have to be careful about the assumptions we make about a code that's used in somebody's record. A while ago, I was looking for all the breast cancer cases in the cohort and thought, okay, that's very simple. There is an ICD-10 code used for breast cancer. Just pull out everybody where that code occurs in their record, and those will be the breast cancer cases. I noticed that in one case, a patient had been put in with a breast cancer code. Then immediately after, there was another record where they had attended the same place, and the coding for that was for having a benign lump in their breast instead of a malignant lump. So this led us to think that what had happened was that the person had been admitted to hospital with a suspected lump in their breast that had a biopsy to see what it was. When they put in the record about having the biopsy, they put it in as being breast cancer was the code because that was why they were doing it. They then found out that in fact it was a benign lump. They put in another record to say they'd been admitted with a benign lump. So just looking for all the records that have got breast cancer coding on it doesn't necessarily give you all the cases, because some of the cases may be false positives. Probably not very many, but in some cases they are. So looking at GP data, we've got a huge amount of it. We've got something like getting over 10 million records for our 20,000 people. That's a good thing about GP data, there's lots of it. The bad thing about it is that it's only been digitized reliably for the last 10 to 50 years at most. Before that, most of the data is in fact not digitized, and it's just still on the paper records. On this graph here, the blue line is the number of appointments per year, and the orange line is the number of records that appear in the data for each appointment. So any appointment these days tends to generate around about 4 records. Some of them may have as much as 10 records, because they may do a whole battery of lab tests and come out with 10 results. There may be a single record, and it's turn up and the doctor says, oh, you've got the flu, go away and take some paracetamol, and they just put in a single record for that. So we then had to look and see, oh, sorry, I've gone too far there. to see how often people actually went to see their GP. And the top graph, we've got the split into male and female. We can see that in our cohort, the female, that's the year of birth is along the bottom here. So the female people in the cohort tend to go and see their GP roughly twice as often as the men do until they get to a late middle age or around about 60, 65. Then they tend to go roughly about the same amount. We also had a look at comparing, we got this data in 2020, towards the end of 2020, and we had a look at the difference made in 2019 and 2020 when COVID restrictions started. You can see April, May 2020, number of people going to see their doctor falls away considerably, as you might expect. Number of appointments falls away considerably. So over the last couple of years, we're going to get basically less data in the GP records than we would have had expected from normal years. The sort of things we get in the GP data, physical examination, these are the commonest things we've got, the top 20. See, whenever you go and see a GP, as soon as you sat down in the chair, they'll probably slap a blood pressure monitor on your arm and check your blood pressure while you're telling them what's wrong with you. So there's an awful lot of recordings of blood pressure. This gives us the opportunity to do a sort of longitudinal graph of how people's blood pressure has varied over the last 10 to 15 years at least, usually. The only difficulty in using it is you have to check that you're using the right combination of codes, because all these codes starting with read codes starting with 246 are all to do with blood pressure. So you have to look at all the 246 codes, not just the ones that you think, oh, that's those two, that's systolic, diastolic, that's all I need. The same applies to height, weight, and BMI. If you don't take the right combination of codes, you will miss some of the measurements. The difficulty in this is obviously there's going to be lots of gaps if there's a long period between somebody going to the GP and getting their blood pressure or BMI measured. We can find out the sort of trajectory of people's blood pressure over time and also their BMI, obesity over time, just by examining their GP records. The lab tests that were ordered by the GPs that turn up in the lab test data that we had results for also turn up in the GP records. So as well as finding out that the GP ordered these tests, we get an idea as to why the GP actually ordered the test, because we can usually look through the battery of tests that were ordered and find a diagnostic code as well, a reason for why they were looking at it. And here we can see one of the commonest ones we had was the ALP that we did the GWAS on earlier. And quite often they'll order a whole battery of tests at the same time. So there may be five or 10 different tests run on the same sample. And the commonest diagnosis we get, again, the diagnoses tend to be mostly general descriptions of symptoms rather than exact diagnoses, mostly to do with high blood pressure, general pains. Pain in the limb isn't a very descriptive code, but back pain is another really common thing. Chest infections, respiratory infections, the sort of thing you'd expect people to be going to see their doctor about. But up here, one of the commonest things, this is my favorite code in all the data we have, which is women going to see their GP about a normal delivery in a completely normal case. If you look at medical records day in, day out, it can get really depressing about looking at all the terrible things that can happen to people and seeing something where it's actually recorded that in this case, everything was just fine. It's actually quite heartening sometimes. How are we doing for time? Okay, nearly 3/4 an hour up. So just a quick word about what we're doing with Generation Scotland. We're about to start new recruitment, which we're really excited about. In fact, Early this afternoon, we actually recorded our first recruit in our new online portal. We're still at the pilot stage of it. This was supposed to happen 2 years ago, but it's taken us a long time to get to the stage where we could actually launch it due to COVID restrictions and many other restrictions. But we're basically looking to double the size of the cohort over the next few years. We're going to get linkage to all their data as described. We're doing remote data capture, doing online questionnaires and getting the DNA from saliva via the post. And also, we're going to try and get linkage to the Guthrie cards, which are the neonatal blood spots, which have been collected for everyone in Scotland since 1965. There's currently a moratorium on their use for research purposes. We've recently been doing a feasibility study. We got permission to do a feasibility study, see how easy it would be to find the Guthrie cards for people in the cohort. We found that we could find them. We could extract DNA from the blood spot on the card even after 25, 30 years. We could then run a methylation assay on that, and we could compare the DNA methylation between the person taken at birth and at the baseline. So we can get a lot of information about changes in DNA methylation this way. We're hoping the moratorium will be lifted. There'll probably be a lot of discussion about that over the next year or two throughout the UK. I think that just about brings me to the end. So I shall stop sharing in a sec, and Dave, you can tell me, has anyone got any questions?
I'll do my best, Archie. So there are a few. I'll just take them in order. I'll shout them out, shall I, Archie? So there's one from Aisley Murray. This question is: did participants consent separately to each category of record linkage, or just a generic medical records box? I do consent. It's just
medical records is the way we described it, and what we're also looking for in our new consent for our new cohort is linkage to administrative records as well. So we're hoping that we can use the link up with Chris Dibbons, some ADR people who have a possibility of linking data from other records. Say we're interested in getting school exam results, would be one thing. There's various other data sets we could try and get linkage for. When we actually get linkage to new data set, we will let the participants know that we're now going to link to this data set. If they want to opt out of it at that stage, then we'll allow them to do that, because at this stage we can't actually tell them what other data sets we're thinking we might be able to get. Just now it's basically your medical records. Anything that comes on the NHS is included as far as we're concerned. And the people already in the study, we don't have that additional consent, but if they join our online portal, we can get that additional consent for administrative records as well.
Great. Here's one from Gary Coleman. Do you have many people in the cohort who move or receive treatment cross-border? And if so, how are these handled?
We don't have many, we think. We know we have some. We're now part of the UK LLC longitudinal something BOL consortium, which is looking to bring together data from cohorts throughout the UK in the Sale safe haven. And Generation Scotland, we've uploaded our people into there. And through doing that, and they have permission for linkage to NHS England and data digital records coming from the English and Welsh NHS. So we'll be able to identify people within Generation Scotland who are on that side of the border and be able to combine their records that way. Is not a simple process at all. And we don't know how feasible it is. We think there's probably not going to be enough people to make it really worth our while going into in any detail. It is possible, but a lot harder.
Here's one from Liz Mansey. Do the GPs use the same electronic medical record system?
No, they don't. In Scotland, they have either Vision or EMIS. 90% of them have got one, and not so many have got the other. I can't remember which is which. I believe in England, there's up to 6 different systems, GP systems in use. And when we get our data extract, we're actually getting this from a third-party company called Albasoft, who are in Inverness, who do the data extracts for NHS Scotland in order for the GP practices to get paid for the number of patients they have registered with them, which is why all the practices have agreed to have this software installed in the first place, because they wouldn't get paid if they didn't have the Albasoft system. The Albasoft system can also extract data from them, and Albasoft combine those two systems, those two data sets together, and resolve any format differences within that. So we're kind of blind to what the differences are, but there are some differences.
Well, here's Alison Murray's got a correction for you. PACS is PACX. That's the picture archiving and communication system, not with an X like in Latin. So there you go. But so, the question she had was, who are the new GS recruits? Was the question.
Who are the new GS recruits? Well, this is the exciting thing, is that we now have consent to recruit people from age 12 upwards. Before they had to be adults aged over 18. We can now do the adult level consent from age 16 upwards in Scotland. But people, teenagers aged 12 to 15, if we get parental consent as well, then we can sign up teenagers as well. So what we're looking to do is to get more family members than families have already got. The ones we didn't get last time around, because we actually had to stop recruitment. We still had people in the pipeline, but we basically ran out of funding back in 2011 and had to stop. So we know there are lots more people we could have got from those families. We've also got people who are too young at the time that we can now recruit, and we can get new families to join up. And we want them to be basically from parts of Scotland where we haven't got much coverage already. So, and also to get more young men into the study. That's the thing. All medical researchers struggle to recruit younger males. So we're interested in trying to get those. So we're hoping that if we can get some teenagers in, this will give us an into the younger male as well. But we'll see.
Oh, and here's an interesting one. Has anyone asked you to send them a copy of all the data you hold about them? And could you do so if they did ask?
Yes, one person did ask us to do that, and yes, we were able to do that. What we didn't actually send them the genotype data, and at that point we didn't have DNA methylation data on that. We could do, but we thought that we said to them, you can have the genotype data as well, but it won't make any sense to you unless you know something about genomics. But we were able to extract the data we have from all our data sets and send it. But that's just the data that we collected. The data the NHS collected, it doesn't belong to us. So if they want all of NHS data, they have to go and ask the NHS. We can't release it to the patient on their behalf. It's a tricky area of governance, and luckily so far only one person has asked to do it, and we hope that nobody else does, to be honest. Also, a few people have also asked to withdraw from the study at various points. Out of our 24,000 that we originally recruited, I think to date 4 people have asked to be withdrawn. So it's not very common, but if somebody does want to withdraw and not take any further part, then we can do that as well.
Good. I don't see any other questions. Can I ask you a quick question, Archie? Because you were mentioning that it's a bit tangential, maybe, but you mentioned Open Safely actually. But what are you doing with them?
It was only in passing, because the interconnection with phenotype algorithms, where for particular conditions they've got a collection of all the codes that you need to look up in order to define what a case is. Say a case of asthma, you go and look at all these asthma codes.
I see. It's something they need as part of their system in your system.
And they developed their own collection of algorithms, which are pretty much the same as the ones that there was another project called Caliber, which has now been amalgamated as part of HDR, HDR UK, where they're doing much the same thing. And the algorithms are much the same, but you can go to 2 different websites to go and look at them.
Yeah.
So
okay,
that's the only thing we've had to do with them in any detail.
Yeah, I see. So let me see if there are any other. I don't see nobody else is. I don't think there's anything else in the chat. Nobody else has their hands up. It's 4:53, so we're time's just about up anyway. So I think that's probably all the questions. So thank you, Archie, for the talk. And I usually say at this point when the next seminar is going to be, it's up on the chat if anyone's interested. So next seminar is on the 27th of May at 10 o'clock, and you can find the link to register in the chat if you're interested in doing that. So
yeah, I should have also said that obviously if somebody comes up with a question that they wanted to ask and hadn't thought of at the time, or just didn't want to ask in public, they can send us an email. I forgot to put the website address on the slides. The comms people will be furious with me. I hope I had the new logo and everything.
There you go.
You can Google us. We have Generation Scotland, easy to find.
Yep. One of the jewels in the crown. So it's lovely to hear about, Archie. Thanks very much, and thanks everybody for turning up. I think that concludes the seminar. So see you next time, I hope. Okay, thanks, folks.
Thank you, everybody.